Welcome to the international webinar themed Blood Cancer and COVID-19 in Maldives and Sri Lanka. On behalf of Lanka Hospitals, I'd like to give a big thank you to our event partners, the Maldivian Blood Service and the Rotary Club of Colombo and Maldives, Rotary District 3220 Sri Lanka and Maldives, for their participation and tremendous support today. I'm very pleased to introduce the three speakers who will be joining us today. Firstly, we have Dr. Saman Hevamana, consultant in clinical hematology, hemato-oncology from Lanka Hospitals in Sri Lanka. Dr. Saman Hevamana graduated from the University of Colombo, Sri Lanka, and successfully completed his MD before moving to the UK. He successfully completed the membership exams of Royal College of Physicians and Royal College of Pathologists, and was subsequently awarded the fellowship for both colleges. In addition, Dr. Hevamana also holds a PhD from UK and has published more than 30 papers in peer-reviewed high-impact factor journals. He's trained in clinical and laboratory hematology in the UK. Thank you for joining us today, sir. Next, joining us, we have Dr. Mohammed Amru Ahmed, consultant in clinical oncology from the Indira Gandhi Memorial Hospital in Maldives. Dr. Ahmed is the first Maldivian medical and radiation oncologist, and this tremendous achievement is a blessing for Maldivian cancer patients. He has completed 5 years of residency in Dhaka, as well as his MD in clinical oncology, and is practicing full-time at IGMH. Our third speaker for today is Dr. Ahmed Umar, Associate Specialist in Pediatrics from the Maldivian Blood Services in Maldives. Dr. Ahmed Umar completed his undergraduate and postgraduate medical studies in Ukraine and further completed a preceptorship in Thalassaemia from Cyprus. He is the head doctor of the Maldivian Blood Service, the main center for thalassaemia patients in Maldives, and has been dedicated to serving the patients for more than 5 years. I'm very grateful for your participation today. So to start off with, I'd like to invite Dr. Mohammed Amru Ahmed to commence the webinar discussing myelomas and lymphomas and the situation of blood cancer in Maldives.
Thank you for this opportunity. Hi. Yes, is my screen visible?
Yes, sir. Yeah.
All right, yeah. So thank you very much for this wonderful opportunity to discuss about the situation of blood cancers in the Maldives in times of COVID-19. We're experiencing a very high surge of cases in the Maldives right now, and our health in resources are stretched very thin. And treatment of cancer right now has been a very challenging journey, especially in these past 2 years because of the pandemic. So let me first begin by talking a bit about the statistics of blood cancers in the Maldives. Unofficial statistics in the years 2017 to 2019 were showing that the fourth and fifth most common cancers in the Maldives were blood cancers, mostly leukemias and lymphomas respectively. So fourth most common was leukemia, and fifth most common cancers, newly diagnosed cases, was lymphoma. And among the 2,110 new cases that were diagnosed between that period, 1,687 cases were blood cancers. Blood cancers being a collective term that includes leukemias, lymphomas, myelomas. And that is very alarming. And we're seeing that leukemias are mostly seen in the younger population. So if you look at worldwide statistics, there are an estimated 300,000 new cases of leukemia. That's around 2.8% of all new cancers, which are diagnosed annually. And there is an estimated 83,000 new cases of Hodgkin lymphoma and an estimated 540 new cases of non-Hodgkin lymphoma diagnosed in 2020 worldwide. These are statistics from WHO body for cancer statistics, Global Can. And uh, so, as a lot of people are probably already aware, the treatment for blood cancers in the Maldives are grueling, very grueling journey because we don't have, at the moment, we don't have um, hematologists present in the Maldives or hemato-oncologists. And most patients of leukemia are treated abroad in countries, mostly India and Sri Lanka. And even though the costs are bared by the national insurance scheme, and the journey to cancer care is very tedious and time consuming. So the patients still need to pay for the stay and transport and food, and it's a huge burden because cancer treatment of blood cancers are not still available here. We still need to establish a lot of infrastructure, as well as we do still need expertise in treating these. And yeah. So one of the main challenges that we're facing right now is the dramatic increase of COVID-19 cases, and we're seeing more and more cancer patients testing positive. And uh, cancer patients are at an increased risk of moderate to severe COVID-19. And among these, blood cancer patients are at even a higher risk of developing severe COVID-19 disease. So after a cancer patient tests positive for COVID, our general recommendation is to stop all cancer treatments, especially those that cause myelosuppression or immunocompromisation. And cancer treatments such as chemotherapy and immunotherapy can suppress the body's immune system, which may give an upper hand to the coronavirus. So we recommend to continue specific cancer treatment only after the cancer patient recovers from COVID-19. That is in most instances. Patients with blood cancer in particular are generally advised to be isolated at home if the symptoms are mild or no symptoms, or at a facility if the patients are severely symptomatic. And even if they are at a facility, we do recommend complete isolation for blood cancer, especially patients with acute leukemias. And regarding vaccination, we do recommend vaccination for patients taking treatment for blood cancers because they are at a higher risk for severe COVID-19 disease. So I'd like to say a few things about lymphomas and myelomas. So this will be very brief. I hope you all can follow. So lymphoma is a cancer of the lymphatic system, which is part of the body's germ-fighting network. So the lymphatic system comprises of the lymph nodes, some extra lymphatic organs like spleen and tonsils, and other lymphoid tissue. These the cells that are involved, the cells that mature from these sites are called lymphocytes, and it includes spleen, thymus, bone marrow, and also tonsils. It can affect other organs as well. In fact, it can affect any organ. And there are mainly two types of lymphoma: Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma has a better prognosis, meaning a better treatment outcome than non-Hodgkin lymphoma, but non-Hodgkin lymphoma is more common than Hodgkin lymphoma worldwide. And the risk factors, commonly it occurs in younger adults, and also there's another peak at age above 55 years. And males mostly have a higher risk of developing lymphoma, though we do see lymphoma cases in women as well. If you have immune any immunosuppressive condition like suffering from HIV/AIDS or taking immunosuppressive drugs like steroids, you are at an increased risk of having uh, lymphoma. So lymphoma is also caused by some specific infections like HIV, Epstein-Barr virus, Helicobacter pylori, mostly for gastric melanomas, gastric lymphoma. Helicobacter pylori is for mostly stomach lymphoma. But most of the cases, the exact cause remains unknown. You can see if in so we suspect lymphoma after the patient presents with some symptoms. So these symptoms can include painless swelling of lymph nodes in your neck, armpits, or groin, persistent fatigue, fever, night sweats, shortness of breath, unexplained weight loss, and itchy skin. So when you see lymph nodes swell, most of the time they happen due to infections mostly. But if the lymph nodes are persisting for more than 4 weeks, 4 to 6 weeks, we usually advise people to get a biopsy. And the treatments are chemotherapy, immunotherapy, radiotherapy, hematopoietic stem cell transplants, and the combination of above, which will be decided by a oncologist or hemato-oncologist. And myelomas are a cancer of the plasma cells, and plasma cells are a type of white blood cells, and they help make antibodies and that recognize pathogens. And cancerous plasma cells produce abnormal proteins rather than useful antibodies. And treatment isn't always necessary right away, as it is a slow-growing chronic disease, and your doctor may recommend close observation initially. So myelomas a lot of the cases they present with no symptoms. Bone pain can happen, particularly spine and chest, nausea, constipation, loss of appetite, confusion, fatigue, frequent infections, weight loss, and excessive thirst. The risk factors are an increasing age. Unlike lymphomas, this is a disease of the elderly group. And mostly this also happens in males. And we see a lot of cases in people from Black race and family history of multiple myeloma. And the treatments are again almost similar. So you get chemotherapy, corticosteroid treatment, immunotherapy, hematopoietic stem cell transplant, as well as radiotherapy. So my message today from my talk that patients patients of blood cancers are at an increased risk of COVID-19 and severe disease thereof. And blood cancer patients should be prioritized when receiving vaccination. And lymphomas and myelomas are highly treatable blood cancers with good clinical outcomes. Thank you. Thank you very much.
Okay, thank you so much, sir, for that insightful presentation and giving us a greater understanding of the blood cancer situation in Maldives. Next, I'd like to invite Dr. Mohammed Ahmed Umar, who is going to be speaking further about thalassemia in Maldives.
Okay, thank you, Anusha. Okay, I hope you all can see my screen. Okay, so I'll be talking about the situation of thalassemia in Maldives, but I know thalassemia is not a blood cancer, but this is the most common blood disorder in the Maldives. So we thought we will include some information about the situation of thalassemia in Maldives. Actually, around 60 to 70% of the blood collected in the whole country is being used for thalassemia patients in Maldives. So you can see how big of a issue thalassemia is in Maldives. First of all, I'll just talk about the situation of thalassemia in Maldives. So we have around 17% of the whole our population, the Maldivian population, are beta thalassemia carriers, and around 12% of the population are alpha thalassemia carriers. So this means like 1 in every 6 Maldivian is a beta thalassemia carrier. So we have a since we are a small population, and we have been the marriage happens usually within the islands. So there's a high chance of 2 beta thalassemia carriers getting married. So projection says that there's actually 1 in every 30 marriage could be between 2 thalassemia carriers. So which means if the marriage happen at this rate, 1 in every 20 child that are born in Maldives could be a thalassemia. So there's a high chance of the birth of a thalassemia. So we have to take initiatives and measures to decrease this chance. And I'll be sharing some more insight into some statistics. You can see that up to today, we have around 906 patients registered at Maldivian Blood Services as thalassemia and other hemoglobinopathy patients. Out of this, 633 are alive till date, and of this, 312 are living in the capital Male area, while the other 321 patients are living in different islands. As per the number of patients being registered per year, on an average, in the past 10 years, we have had around 18 patients per year, and you can see the number of patients being registered each year from 2011. You can see there's a slight decrease in the number of patients being registered, although we see a increase in 2018 and also an increase in this year, which I will look into the reason of this in a couple of slides later. Okay, so we have actually, other than beta and alpha thalassemia carriers, we have 3 other hemoglobinopathies that is being commonly found in Maldives. They are hemoglobin E, hemoglobin D, and sickle cell. So these 3 hemoglobinopathies are also found in Maldives, but we see pockets of these carriers in different islands. Okay, so talking about the prevention, there has been a Thalassaemia Act which has been passed by the Parliament in 2012. According to the Article 11A of this Act, it is actually a responsibility of each and every parent to have their child tested for thalassemia and to keep the record of this with them before the age of 18. But it is not practiced very well in the country, throughout the country. But there are facilities for the testing. It has been widened to other parts of the country. So right now, thalassemia screening services is available at our center, Maldivian Blood Services, as well as there's a private party providing this service, Society for Health Education, and this service has been established in all the regional and atoll hospitals to facilitate for the general public to get the service much easily. With regard to DNA analysis or mutation analysis for beta and alpha thalassemia, this service is currently only available at the Society for Health Education. Only this service is available there, but because of this, we have a difficulty in, especially in the islands, those who cannot get a proper screening result to get a definitive diagnosis of their condition. So this is actually one of the challenges we have in the control, prevention and control of thalassemia in our country. About the management of thalassemia patients, so according to the Thalassaemia Act, all registered thalassemia patients should receive free of cost medical service in the Maldives. So in the Greater Malay region, we provide the blood transfusion and iron chelation medication to the patients at our center, the Maldivian Blood Services. And for the patients living in the islands, their blood transfusion is available at another 86 islands. So it may not be available in each and every island, but usually those patients who are living in islands where transfusion is not available, they travel to the nearby islands to get the regular transfusion. And chelation medication is being provided through the state-owned pharmacies in the island of residence. So this was initiated recently in 2018. So this actually made a great impact on the compliance of patients to chelation in the islands. And as far for the bone marrow transplant, which is a potential cure for thalassemia, service is not available in our country, and the patients are referred abroad. Currently, we are referring them to our neighboring countries like India and Sri Lanka. Just I will highlight some more challenges we face. So as I mentioned previously, the DNA analysis service is only available in the private sector. So this service has to be paid to obtain. So for the general public, there is difficulty in obtaining this service. And also prenatal diagnosis service, which is a key component in the prevention and control of thalassemia. This service is also not available in the country. And those who need this service obtain it usually from India. What I wanted to highlight about this is since this service is not available in our country, we have seen the surge and the increase in the number of patients this year. Because last year, due to COVID-19, the families could not who wanted to get the PNDs done were not able to travel to India to get the service. And this year we are seeing most of the patients who are being registered this year have the same story, that they were ready to go and check the baby with a prenatal diagnosis, but they were unable to travel. So I think this is one area where we need to work on to establish this service in Maldives, so that we can decrease the number of birth of thalassemics. And also Dr. Amr also has mentioned in his presentation that currently we do not have any hematologist in our country. So this is a challenge for the thalassemics treatment as well. So we lack specialists, and also not only hematology side, but also we lack specialists from other disciplinaries, because usually the adult thalassaemic patients, they require multidisciplinary care where we need input from specialties like cardiology and endocrinology. So recently only we had our first Maldivian endocrinologist also started working at Indira Gandhi Memorial Hospital. And I'm very happy to say that we have a good connection with him, and he is helping a lot in the treatment of our patients. So hopefully in the future we will have input from other disciplinaries as well, so that we can provide the multidisciplinary care to all our patients. And also another challenge we face is the high turnout of medical professionals, especially in the periphery. So most of the time, the doctors and nurses and other health professionals working in the periphery are foreigners. So there is a high turnout of these professionals in the periphery. And with COVID-19, the biggest challenge for our thalassaemic patients were to obtain blood. We had a huge impact on the blood donors due to COVID-19, as well as due to the restrictions implemented by the government to constrain the spread of the disease. But we had a high turnout of voluntary donors during the pandemic, and that was I would say an achievement to our thalassaemic and the blood services. So basically, that is all I would like to highlight. And thank you for listening.
Thank you, sir, for giving us a vital presentation on thalassemia, which is very crucial with the Maldives currently having the highest prevalence of thalassemia in the world. Now I'd like to invite Dr. Saman Hevamana, who will be discussing the COVID situation affecting blood patients on an international scale.
Thank you very much for asking me to participate from the end of Lanka Hospital. I'm going to give some evidence to what the first speaker talked about. I'm going to talk about how blood cancer patients are affected by COVID situation in Sri Lanka. And we have come to a critical state, as I can see in Sri Lanka, as you have described in Maldives. We see more and more patients getting affected and also increased mortality. I had a little taste of this when I was working in the UK from February 2020 to May 2020. During those 3-4 months, we saw about 1,000 patients died from COVID-19 infection, and also unfortunately had to experience our own patients who are on treatment for blood cancers suffering and dying due to COVID-19. So bit of that we are seeing now in Sri Lanka. I'm going to tell you about prevention, patient and staff, and how what are the hematological manifestations of COVID-19 generally, and why and how this affect blood cancer patients. Probably I'm not going to talk about the treatment, and then I will show you some slides about the audit we did recently in Lanka Hospital Blood Cancer Center. I come here on part-time basis from the UK. Unfortunately, I don't have all the statistics about incidence of blood cancers in Sri Lanka like our Maldivian colleagues presented. One of the interesting things about COVID affecting cancer patients is, it was highlighted in this paper where they say we diagnose 54 less now. So is it good diagnosing less cancer patients, or is there a problem behind that? Now, the real reason for not diagnosing is patient reduction, or patients are reluctant to come to the doctor. This is data from the UK, not from Sri Lanka. So we see only 50% of the cancers compared to what we used to see. And also partly because less doctors are performing investigations, and you can see here, all the resources get drained towards COVID, and cancer care is getting compromised. So there is a real danger behind this, which was highlighted by this editorial in the Lancet few months back, where it says, due to COVID, we diagnose less and we treat less, and that can cause a huge impact on the cancer care in the future. In years to come, we probably will see a lot of late stage presentations or people who are defaulted, so who has not completed their treatment due to COVID situation which is prevailing now. And there are a lot of hematological complications or findings in patients with COVID-19. These are not blood cancer patients as highlighted by this review. It can affect the blood cancer and the biochemistry. And also in our patients, blood cancer patients, we need to be cautious about interpreting some of the prognostic markers or biomarkers, where otherwise there are clear guidelines about treatment when it comes to COVID infections in non-cancer patients. And also it can cause complications related to coagulopathy. This is not necessarily in blood cancer patients. This is hematological problems in patients who has got COVID infection. And this is a familiar picture for hematologists. I'm sorry to hear that you haven't got any hematologists in the Maldives. And we look at these pretty cells every day. These are reactive lymphocytes. These are lymphoplasmacytoid lymphocytes. These are what we call LGLs. These are very dysplastic neutrophils. All these are very common under the microscope due to prevailing COVID situation when we see blood cancers. Now, when it comes to, one of my colleagues told the first speaker, and this is the evidence, if somebody with blood cancer get COVID, there's a very, very high risk of getting complications and death. From this British Journal of Hematology publication, you can see, which can go up to 25%. That is the mortality on the second graph on the right. Unfortunately, I don't have a highlighter, where if you can look at the cursor, like now, this is the mortality which can go up to about more than 25%. If you look at the general mortality of COVID-19, there are different publications giving different figures, but generally it is about 0.5 or 1% maximum. When it comes to cancer patients, unfortunately, we see more and more patients getting complications and death. And there is another important factor when blood cancer patients get COVID-19. And generally, we consider patients are not risky to others in terms of infecting others after 10 or 14 days. But blood cancer patients can have prolonged viral shedding. That means they can be infective to others more than somebody with normal immunity. And again, there are thousands or millions of publications, starting from the original publications from Yuan, China, about the increased risk to cancer patients. Yet another publication from UK to show how important is preventive measures, and there is no such specific treatment for COVID-19 patients when they get infection. Again, one of my colleagues mentioned that we stop all immuno and myelosuppressive treatment. That's the general advice. In addition to that, there is no specific treatment directed at cancer patients who get COVID, despite very high risk of death. Of course, there is a way out, and there are various guidelines, again starting from China. This was published in the Lancet. Guidelines how to manage cancer patients. So what do we do during this pandemic as cancer doctors? And this is one, and then there are very nice Australian New Zealand guidelines, and also of course from where I got trained or I work, from the Great Britain, there are British guidelines how to minimize the risk of patients or staff getting COVID infections. And that includes preventing patients coming to see us and minimize the clinic visits. And we use growth factors, we use prophylactic antibiotics. This is not to prevent COVID infections. This has nothing to do with corona, but this will minimize patients coming into hospitals and will allow them to stay at home. So that way we can prevent them getting infections. And also these guidelines target visitors, the workforce, the phlebotomists, and how to give chemotherapy. Now, as I showed you in first two slides, if you delay curative chemotherapy, we are going to see more and more cancer patients at late stage or people who have not completed their treatment later on. It's important to live with COVID and handle this at the same time. So what do? We get more staff, and it is very easy to tell. And even in the hospital I work, is a constant battle getting nursing staff. But there is very clear evidence, whether it's related to COVID or anything else, whether strokes, heart attacks, anything, your nurse number plays a very important role. So having more nurses, having more staff, having more space will minimize the infections between patients and staff. And again, at the same time, you need to protect them. And there is very hard evidence to show that personal protective equipment works in preventing patients as well as staff. And I remember when I was working in the UK in last mid-March, where everybody believed the face masks won't work, and we were supposed to work in the NHS without mask. That was the WHO advice. That was a difficult time because we didn't know how people got it, but generally people were advised not to wear mask or whether the masks were not necessary. Now the things have changed, and there is very, very clear evidence. Your personal protective equipment, mask, goggles, face shields, and gowns, that will prevent you and your patients. The most important thing as it stands at the moment, and the mostly unregulated thing in the part of world I work today, in the developing world, we have got this vaccination program completely messed up in my view. And in the UK, by the Joint Committee on Vaccination, they have given very clear recommendations and guidelines. And this is an unbreakable rule in the West that you follow these guidelines. So where does our patients come with blood cancers or cancers? It's on the number 4. People age 70 years and over or 16 and over, but clinically extremely vulnerable. So the 4th group on this guideline, the British guideline, is where our cancer patients come. So they have vaccinated first resident care home, old adults, they are the highest risk, then 80 and over, and the frontline healthcare, social care workers, people 70 and over, then 70 and over, and the blood cancer. So unless a blood cancer patient qualifies to an earlier group on their age, so suppose like now I have a leukemia patient who is 80, he will be under number 2. But anybody else above 16 with the blood cancer, they will get the vaccination at the 4th level, which in the UK they have completed, but unfortunately, we haven't reached that, or we haven't got this far in Sri Lanka. And I hope that all our blood cancer patients will get vaccinated soon. That is one of the very important things to prevent the mortality. And again, like one of my colleagues previously mentioned, can I have the COVID vaccine while I'm on cancer treatment? Now, what we mentioned was if you get COVID infection, the general advice is to stop anti-cancer treatment. Not everything, but particularly myelo and immunosuppressive treatment. Now, while you're on chemotherapy, can you have COVID vaccine? The very simple and the straight answer is yes. Yes, you can have your COVID vaccine, and everybody with blood cancer particularly should be vaccinated. These are the guidelines by the Joint UK Chemotherapy Board, where clinical oncologists, the hemato-oncologists and clinical hematologists participate. And there is in the small print, there is some advice about how to time the vaccine. One of the biggest problems is you can have the vaccine. There are no evidence to say that you can have more side effects, but the efficacy or the seroconversion or the effectiveness of this vaccine can be lower than people with normal immune system. We'll skip this. This is again not related to cancer. This is about general advice about vaccination for people who are on antiplatelets and anticoagulants. Now, this is the last one or two slides. This is one of the bright spots about, as I started, this is not going to go away easily. So we have to do both treating cancer patients and preventing COVID as much as possible. In the hospital I work, in the Lanka Hospital Blood Cancer Center, from April last year, that is April 2020, we introduced a screening checklist for all the patients and for staff. And this is a screenshot of the screening checklist we use. And also, there was now when we use the screening checklist and we did an audit collecting data from April to December to see how many patients we have. These are patient episodes. During the 8-month period, we have had 422 inpatients, and we had 977 day cases, that is hematology day unit. And you can see the distribution of their diseases here. And we have performed on using this clinical risk stratification or clinical risk questionnaire. We decided only on 19 patients that they will need a PCR, and none of them became positive. There were 2 patients who became positive, whom we advised not to come to the hospital because we thought on the clinical questionnaire they were at a very high risk. I consider this is a great success. Seeing this many patients, again, this is the distribution of those patients who came to as inpatients, nearly 500 and more than nearly 1,000 patients. And you can see they are not young, they are highly vulnerable patients who are more than 60 with the blood cancer. And being able to, and on the disease classification, there are few patients who are on who had bone marrow transplants, and you can see how many acute leukemia. So they are patients where we cannot postpone chemotherapy, and we have shown if you are careful, if you adhere to proper guidelines, you can manage this situation and at the same time maintain the service. And again, we compare this with what we did in 2019. Though there are ups and downs which are not statistically significant, we have managed to continue to care roughly for the same number of patients during the COVID period. When you compare with the same time period from April to December before we had COVID in 2019. And again, thank you very much for all my colleagues from the marketing department and the Lanka Hospital management. And the take-home message is the COVID is not going to go away. And if you delay treatment, if you delay the diagnosis, in a couple of years, we are going to see a surge of cancer patients who are late in diagnosis, late in presentation, and who has not completed treatment. We published this, what we did in Sri Lanka in relation to acute myeloid leukemia. There were some patients even in this publication where we managed to treat during the COVID period without compromising care. Thank you very much.
Thank you very much, sir. And for enlightening us thoroughly on the situation of blood cancer and COVID-19. Now, next we'll be moving on to the discussion round where we'll be answering some of our most common questions. Right, so now we'll be going on to the discussion round. So we have a number of questions from our viewers at the moment. Right. So the first question I'd like to ask is the COVID vaccine safe for blood cancer patients? So, for example, Sinopharm vaccine is being administered to 60 plus people in some areas, but it has not been recommended as some sources say. So is it safe for a myeloma patient, and how can they get a better understanding of the vaccine that is recommended for them?
Whether the vaccines are safe for cancer patients or not. So far, actually, to be very honest, data coming from Sinopharm is still very limited. So, in general, vaccines are safe. COVID vaccines are safe for cancer patients. If a country does have facilities for vaccines like Pfizer and Moderna or Johnson and Johnson's, those would be better recommended than Sinopharm. But due to the sole fact that still data from Sinopharm vaccine studies are still limited. But if in countries like ours where we don't have those options, it is still much better to go for whichever vaccine is available, because we're looking at, as we have, as Dr. Saman has also pointed out, that the mortality rate for patients with blood cancer for COVID-19 is very high. And we should definitely use whatever is at our disposal to decrease the risk of severe COVID-19 disease and subsequent death. So yes, the answer is, in short, Sinopharm vaccine is recommended for blood cancer patients.
Thank you, sir. Sorry for the delay. So the second question that we have is for Dr. Ahmed Umar. So studies have found that blood cancer patients were particularly at risk, with 57% higher odds of severe disease if they contract COVID-19. What are the best precautionary measures to be taken by patients during the pandemic?
So basically, the precautionary measures are similar to the general public. Avoid going into crowded areas. It's best to keep indoors and wear face mask if you are going out. Keep social distance while you are outside. It is basically the same, but they have to take. They have to be more careful and take extra precaution in be extra careful to follow all the precautionary measures. If anybody else want to add anything, Dr. Saman?
Yeah, for blood cancer patients, again, like my experience mainly come from the UK, not from Sri Lanka. Now, they have divided blood cancer patients into several groups. Now, people who had cancer treatment more than 5 years back, and if they are in complete remission, they have to take precautions as the general public, but be cautious that they are still at a higher risk. Now, people who are on active treatment, there is a process called shielding. So that is not isolation. What we did in the UK from March to April, during the time I was working there actively in the NHS, was we advised them shielding. Shielding is a different process where you have no human contact at all. So they cannot go out even with a mask. So they stay at home and nobody else should stay in that house. So they are completely, it's a very psychologically damaging situation. So you go and leave their food outside, like you are treating a COVID positive patient in isolation. So they followed this, you can get the proper guideline on the NHS website, how to do the shielding. So it's not self-isolation, that is the shielding. So all alone and no contact, and only their food will be left outside the door. That is similar to, like, these are people with blood cancer not having COVID, but you treat them as somebody who will give a disease to you. So you just stay away from them with the idea that you don't pass anything to them. So that is the advice for the high-risk patients, elderly who are on active treatment with active cancer.
Thank you very much, sir. All right, so the final question is, what would happen if tested positive? What is the clinical course of treatment, a clinical course of COVID for patients with blood cancer? Dr. Saman and Dr. Mohammed would be able to answer that.
Now, it's a very difficult question to answer. What would happen if tested positive? Now, like the general population, there is a big percentage of people who are with blood cancers, depending on whether they have active cancer or, as I previously mentioned, somebody with blood cancer, suppose like a lymphoma in remission for last 5 years, will have a slightly higher risk than the general population to get into complications and death. But if somebody is on active chemotherapy or finished chemotherapy recently, which can be a few months or few years even, they are at a higher risk of getting complications and death. So that's what I generally believe. The prevention, vaccination, or more than that, your 1 meter distance, the masks, and the general steps we take to prevent getting tested positive is the best way to live during this pandemic.
Thank you very much, sir, for that great insight. Now that that brings us to the end of our discussion round. So I'd like to thank again very much Dr. Saman Hevamana, Dr. Mohammed Amru Ahmed, and Dr. Ahmed Umar for sharing your wonderful knowledge and providing a great insight into blood cancer during the COVID pandemic in Sri Lanka and Maldives. And we have received a number of questions on Facebook and the chat forum as well, which we will reply to on the Facebook post page. And I'd also like to thank our event partners once again, the Maldivian Blood Services and the Rotary Club of Colombo and Maldives, Rotary Club of District 3220 for supporting us throughout this event. Thank you again, sirs, for taking part.
All right. Thank you very much.
Yeah, thank you very much.
Thank you.